Good evening. I'm Dr. Jeffrey Spear, current president of the El Paso County Medical Society for 2022. We at the El Paso County Medical Society are very proud of this program. We are certainly grateful for the collaboration of both Star City Studios and KCOS for making this program a reality. We're also incredibly grateful to Ms. Catherine Berg, who has been such a terrific partner for the last 25 years being this program's host. We hope you continue to join us each and every month for this fantastic program, and please enjoy the presentation tonight. Thank you very much.
Good evening. This evening on the El Paso Physician, we're going to be talking about pediatric surgeons and conditions that happen here in the borderland. Pediatric surgeons diagnose, treat, and manage children's surgical needs, which are very different from adult surgical needs. And we have specific issues and conditions that happen specifically here on the borderland that don't happen in other areas around the country. We're going to be talking about that this evening. The program is underwritten by El Paso Children's Hospital, and always a huge thank you to the El Paso County Medical Society, who's been bringing this program to you for over 25 years. Thanks again for joining us. We are here this evening discussing pediatric surgeons and conditions specifically here in the borderland. And Dr. Diamond, we were talking prior to the show. This is Dr. Sean Diamond, who is a plastic hand and microsurgeon. And we were talking a couple of, months back about brachial plexus, but there's a lot of other things that you do, which are absolutely fascinating. And being part of just being a pediatric surgeon in general, you're looking at a lot of bones and ligaments and growth plates that aren't finished yet. So your specialty is just spot on with what you're doing. And I'd like for you, I know we joked earlier, I said, one of my questions is going to be, what do you do all day, every day? And you showed me photographs and videos of what you do, which we're going to put into the show later on as well. But if you were able to verbalize that and explain that to our audience, how would you describe what you do all day, every day?
Yeah, it's tough, right? I mean, plastic hand microsurgery, that's a mouthful.
Right.
And there's a ton of variety. And as you really explained nicely, the hands are a really complex organ. As you know, there's skin, tendons, nerves, arteries, bones, veins, ligaments, growth, you name them all. That was very impressive. Mm-hmm. And so plastic surgery, why am I doing this? I mean, what in the world? It's really the surgery of these really complex tissues that have to all work in orchestra as one. And what we didn't mention is it all has to work to move and to function and to reach out and touch the world and be able to play a piano or do sports or get people back to their life. And that's the fascinating and really fun part about hand surgery. Mm-hmm. And I'm lucky that I work with kids because they just heal and recover like gangbusters. Kids are amazing in that way, meaning they can get really hurt and you can fix their hands, and they do fantastic because they don't even need therapy. They just start moving and doing things. And on the other side, kids born without parts, meaning born without a hand or born without fingers, also do extremely well, meaning I know NFL football players, champion surfers, really can go on and do anything they want to do. So it's fun working in a specialty where there's no losing. So.
Yeah, I love that. No losing, and very little. I don't know if we're allowed to say no, but very little. But I like what you talked about earlier, and we were talking about when you said outgrowth issues. So this is children that are born with maybe, their hand is not necessarily all there, or maybe they've got a couple of tips of the fingers and their arms stop short. When you're talking about outgrowths, you were talking about first how a child doesn't know that they don't have the extra hand. It's just that's how they operate. And you said often you don't talk about prosthetics with the family, with the parents until years after their birth, 3, 4, 5, 6 years, if even then, because you said also sometimes the child will just know how to do better without a prosthetic than with a prosthetic. I'd love for you to take that for a little bit and explain that to us, because sometimes we look around the world and we're thinking, well, we can make you a hand, we can make you a foot, we can make you a knee and a leg. But maybe sometimes you don't want to. And talk about why.
No, that's right. Well, we can't quite make a hand yet. It's pretty complicated.
Yes.
We can transplant hands. And there has been a pediatric patient who's undergone bilateral, meaning both hands, transplanted at the University of Pennsylvania at CHOP and Children's. That is a one-off, meaning it's so rare, and it's because he was born with hands and lost the hands to infection. So he already knew how to use a hand.
Okay.
Now imagine being born without a part. Like, you're born without a unicorn horn. What if you just grow up and you're 5 years old and someone just sticks a unicorn horn on your forehead?
What do I do with this thing?
You're not going to know how to use it. It's
Right.
like, who knows? So that's the issue, right? If you're born without a major part, is maybe in the future we can transplant or put on. And just like a prosthetic, maybe you can, but it's a learned behavior, meaning they have to learn how to use a prosthetic. They have to learn how to keep it on, et cetera, et cetera. And like I said before, kids do amazing on their own. They just learn how to use their body and adapt in a different way than people born with 5 fingers.
Right. And on that note, and again, we'll show some graphics throughout the program as well, but talk about fingers, because we'll see these that are fused together at birth. And what is it that you are able to do? When you said earlier, a hand is complex. So we're talking about, and we joked earlier, and actually I'm going to have you have some fun with tubing.
Sure.
Okay, talk about what you told me about surgeries are all about tubing.
Yeah, I mean, we don't have that. I mean, we have a ton of body parts, and then that at the same time, we don't have that many, meaning
Right.
we have lots of tubes. We
Right.
have ear tubes, we have intestines, which are tubes. The gallbladder essentially is a blind ending tube. An appendix is a tube with a blind end. What else did we say?
We were talking about, when
are
I'm thinking about the
tubes.
hands, we're talking about arteries, we're
Yeah.
talking about veins, we're
Yeah.
talking about all the nervous system that goes
That's
in
right.
there. It's all the tubing that belongs.
That's
and then
right.
you've got the fingers that aren't tubes, but they look like tubes.
All right, cool. So now let's break down all of medical pathology into this very easy, keep it simple method of saying tubes can be blocked,
Right.
which is like a blood clot, right? Tubes can pop, which is like a ruptured appendicitis. And tubes can tear, which is like a aorta problem in a young person with Marfan syndrome sort of thing, aortic dissection. What else do we say tubes can do? Tubes can be infected.
They can be infected,
Right.
pop,
That's
like
an
you said,
itis.
yeah. And you're talking
That's-
about ears, intestines, all that we'd already gone through. But yeah, absolutely.
That's all it is.
And so I'm thinking reconnection. So if you're looking at veins, reconnecting one vein to a new vein, again, in hands, if you are doing hand, not replacements, but yeah, hand replacements, I guess, when you're looking at a donation of a hand through a circumstance, there are nerves in the hand that need to be connected to the nerves that are already in the wrist, that connect to the arm, that connect to the brain, et cetera, et cetera. So those tubings are what fascinate me.
Yeah.
And how can you connect a tube situation from another person to now a tube to the person who's going to be using it? You know where I'm going.
Well,
on
let's
this,
make
right?
it easy. Let's just say it's the same person.
Okay.
Because it's, again, really rare that we're talking about transplant.
Yes.
Although plastic surgeons, they did win the Nobel Prize for inventing transplantation. So we not only do all the aesthetic stuff, but we do have some brains too. But
Yeah.
anyhow, tube connection. So let's say a young person cuts their wrist with glass and cuts the nerves and the arteries to the hand at the level of the wrist. The way I typically will reconnect those is with either really powerful loops, which are those doctor glasses that have those long things coming off them that magnify your operating field, or with an operating room microscope. But I sort of see the world in microsurgery, which is to look at one of those blood vessels and you can see all the different parts of it, the adventitia on the outside, the media on the inside, and then the luminum in the inside. And it's just amazing what you can see with light, optics, and magnification, and instrumentation, meaning our instruments need to be able to work on those very fine parts. And we can reconnect blood vessels suture by suture. Usually those stitches are like the 10th of a human hair.
Jeez.
And
how,
nerve.
I'm going to stop you there
Yeah.
because I don't understand that. I have a hard time comprehending how, I know you got micro glasses on. I get that. But just the instruments that you would require to grab onto something that small.
No, that's
and
right.
what is assisting you with that?
So talking about hands,
Yeah.
operating is to do with the hands, meaning I don't use a robot or a stick. It's very tactile. So I have a surgical instrument in my hand that looks like a needle driver, but it's very fine and it reaches out and it grasps that very fine suture needle and it's laser wedged onto that thing that's less than a human hair.
Okay.
And underneath the microscope, I'm physically looking at myself throwing each suture. So it's a very tactile, human thing. It's very cool.
So if you're looking at, and I don't even want to even try to get into sizes. So if we're looking at pediatrics, and a lot of the videos that I saw are of toddler age, I would say, so we're like 1 or 2 years of age. And so when you're looking at the nerve endings in a hand, how many might one have going from the wrist into the hand? And let's just first talk about these transplants, and then let's talk about these fingers that you just did. So let's talk about the transplants first, because I know that's big and grandiose, and get that out of the way. And then we can talk about being able to move 2 or 3 fingers that you showed me earlier today.
Sure. So we have 3 major nerves from the wrist going into the hand: the median nerve, the radial sensory nerve, and the ulnar nerve. Each
Okay.
of those in a little kid are probably on the order of about 5 to 7 millimeters. In adult, it's probably 7 to 10 millimeters. So they're sizable things. They look like big, thick linguinis. And on the inside of those are smaller and smaller and smaller and tiny little fascicles. It's sort of like if you cut an electrical cord and see each of the little wires inside, that's what a nerve kind of looks like.
Okay.
And then as far as repair, we suture. And nerve ending wise, they all go out into the fingers, meaning you can map each one of those nerves, and we're very cognizant of all of them as we're operating on hands.
So when you map a nerve, what does that mean?
That means we know its usual course. And for nerves that are injured, sometimes we'll use a nerve stimulator in the operating room. And even though the patient is asleep, you can actually use a small stimulator and watch the function of the nerve and gather a sense as to if the nerve is functional or not based on how well it stimulates the muscles downstream of it. So let's say the nerve going into the bicep, if I use a nerve stimulator on a healthy person on an operating room table, their hand will usually slap me in the face.
Interesting.
And if
So you know this immediately while you're in surgery. You
100%.
can check that out.
Real time.
Okay. 100% real time. Okay. So when we are looking at 3 fingers now, or 2 fingers that are severed together, for the lack of a better word, are you looking at, in these surgeries that you've done, are you also splitting the bones apart? Are the bones already split apart? You're just doing soft tissue, or all of the above, depending on what the situation is?
It's all of the above depending. And that's
Okay.
a great question because everything comes basically in rainbow flavors. There's no one syndactyly, which is the condition you're talking about, which is connected fingers or webbed fingers, they're sort of called. The most common one is a connection between the middle and ring finger statistically. Oftentimes they involve the entire length of the digit, so we call it complete.
Okay.
Incomplete means it's not the whole length of the digits. Simple means it's just skin only. Usually it's like skin, fat, they share a nerve and an artery which can be separated. And then complex means they have connections of the bones, that we have to separate parts of bones or even extra digits inside of that connection.
That's the other one I want to ask you about before we're done. Okay,
Yeah.
sorry. My
and
apologies.
then the very
Yeah.
last one is those hands that are complicated. And what we mean by that is that they're associated with other syndromes. So there's other hand differences that are related to, for example, craniofacial syndromes, where
Okay.
the kids look, at least in their face, different than others. And you can gather a sense that they may have something like an Apert type syndrome,
Okay.
which is something to do with a different appearance and also with clefted hands or with attached fingers.
So if you don't mind, explain what Aper syndrome or an Aper syndrome might be for someone like me that doesn't know.
Yeah, no, this would be great to have our oral maxillofacial team and cranial team here because it is a syndrome that involves the frontal bones and the craniofacial skeleton, and
Okay.
it involves differently than others. Sutures are prematurely fused about the same time that fingers are prematurely fused.
Interesting.
And it all goes
Okay.
together. And these are kids that require a team of both craniofacial surgeons and hand surgeons at the same time.
So usually, and I know we talked a little bit about this prior to the show, but we were talking about sonograms, we were talking about MRIs done fetally or while mom is still pregnant. Are these things that you can see prior to giving birth? And then I guess the next question is when is the best time to do these surgeries? And I know, again, everything's different and every case is different, but in general, you want the baby to thrive for a while first to...
Yep.
Okay.
So those are two great questions. Firstly, women getting a prenatal anatomy scan, meaning those 3D scans with ultrasound, are they're very high resolution. So you can see a lot of different hand issues. And so I take and have seen patients who are mothers at the time, and they'll usually get those scans in the early third trimester, and I'll see them during their pregnancy just to talk about what to expect. As far as surgical timing for patients that need surgery, because again, a lot of my patients don't, meaning we really have a discussion with the family and talk about what our goals are, et cetera. And like we already said, plenty of kids do fantastic keeping things as they were born. But for certain things, for both function and aesthetics and future to avoid teasing in school, et cetera, we do decide on surgery. And for the most part, I'm doing hand surgeries at about 1 year of age.
Okay.
And there's reasons for that, right?
Yeah.
So anesthesia is safe and their hand is big.
And their hand is big. I get it. You've got a newborn, 6 months, a year is pretty large at
That's
that point.
right.
Okay. When you say their hand is big, if you were to wait until 2 years or 3 years,
Yep.
would there be functionality differences? Because you talked in the beginning of the program how a child learns how to adapt with what they have.
Yeah.
Does that factor into the idea that you kind of don't want to do it more than 1 or 2 or 3 years?
It does. So I would say 1 year is kind of the common ground that I look for, but between 1 and 2, the hand doubles in size again and just makes my job so much easier because I'm dealing with big parts that are easier to work
I
with.
love how you call them big parts.
I mean, it's
at a
big
year
parts.
old, goodness. Yeah.
So about age 3, and there's a whole, there's a very clear algorithm of how a normal developing child goes on to use their hands, meaning you can see they grab and reach, and then they start crossing midline, and then they can rake, which means physically pull an object into their palm from outside. And then eventually about age 3, 4, they start learning what their thumb is.
Okay.
And the thumb is the most important part of the hand. It's about 50% of hand function.
You said that's about age 3.
And that's
I
probably
would think
about,
it'd be earlier than that. I guess not. Okay.
it's about age 3 when it becomes critical.
Interesting.
And there may be sort of non-reversible things happening, so that if a child doesn't have a thumb by about age 3, 4, and you need to, for example, make a thumb for them, it probably ought to happen sometime very early so that they can have that brain plasticity. Because again, it's that old thing of
That muscle memory.
Not born with a thumb,
Yeah.
kind of not born with a unicorn horn. And if you wait too long, they may not learn how to use it perfectly. But in other words, there's young children born without a thumb at all, and we will use their index finger for a thumb.
So that's the perfect transition. You were showing some video and some footage earlier. So I want to go first to when there are extra digits. I want to say that there was a foot with maybe 7 toes, 6, 7 toes.
Sure.
So when we're looking at, yes, aesthetics, but also growing up too, that shoes aren't going to fit with
right.
that many extra digits.
That's
So
right.
there are reasons to have these type of surgeries. So how would you then go into, is it simply amputation and then adapting it from there? And nothing simple. That was a wrong word to use. But describe how you would, a toe with 7 digits.
Yep.
A foot with 7 digits. How do you deal with that surgery?
No, I mean, nothing is simple. I think that's the perfect way to put it. And again, all of these feet have all kinds of parts. And what we're looking at is creating a balanced foot or a balanced hand that we know is going to grow uniformly. And the long story short is that even with an extra, let's make it simpler and say thumb, just because I deal with extra thumbs pretty often. That extra thumb is often borrowing ligaments or tendons from the one we're going to keep. So when we remove it, we also keep the usable parts.
Okay.
And that's a huge principle of hand surgery, because in hands there's so many parts, and we call it spare part surgery. And so we're borrowing those parts that are usable, workable, perfect, and they're going to help the thumb that we're going to keep. So we rebalance the ligaments, we rebalance the tendons, and we use part of the skin to reshape the skin and make it look right, make it look perfect, work perfect, grow outward straight as an arrow, and that's what we're doing.
And I like when you were talking about the reshaping and the balancing of the foot. And I know we had a program not too long ago, but we were looking at the fibia bone. And I know this is not feet, but the fibia bone in the leg is used as the spare part bone.
It is.
And so I've learned all kinds of things about spare parts.
It is. You've learned microsurgery already.
Yes, exactly. And so we were talking a little bit about microsurgery, and this is where my joke about all the tubing comes in.
Yeah.
Because when you're looking at reconnecting everything, to me, that's fascinating. So now taking it to creating a thumb, because that is an opposable figure. I mean, that's what separates us from so many other animals.
That's right.
When there is no thumb and you are trying to create, not make a hand, but for the lack of a better word, create a hand as much as you can that isn't there, and digits. I know you could talk 5 hours on this one, but I'm curious, how does one do that? Is there, I say that with the fibia, because if there's not tissue or bones there in the hand, say it was an outgrowth type of a situation, where do you get that tissue and bone from?
So the operation is called policization, and it's kind of the penultimate hand surgery operation. It's a beautiful, elegant surgery that's been getting refined and refined and refined over again. We'll never get it as perfect as we can, and we've been working on it for some 90 to 100 years at this point. And that operation is using an index finger and turning it into a thumb. And it sounds simple, conceptually. You're just like, yeah, it's a finger, just trade out, not a problem. It's complex in the way that you have to reseat the index finger in a thumb position, meaning if you look at your own hands, a thumb is in a very different place than the other four fingers, and so you have to rotate that index finger all the way around.
And how the joint works?
You have to keep the joints and remake what's called a carpometacarpal joint, which is this saddle joint all the way at the bottom of your hand, forward. In order to rotate it, you need to ligate, meaning clip one of the arteries to the index finger, but be careful to preserve the other, because that's the only way it's going to have blood flow. You rebalance the tendons and make the flexor tendon of the index finger into a new flexor tendon of a thumb, and vice versa. And then you rebalance a lot of the different muscles, and I could go on and on and on, because again, it's been this deal that's been getting refined for decades. But long story short, you end up with a 4-finger hand. If you meet someone in your life with a 4-finger hand who had this operation, I would be hard pressed that you would notice walking down the street or even shaking their hand that they have a 4-finger hand. So we call it a Simpson's hand, but I'm telling you, if done very nicely, which often they are, you would never know that someone's missing a finger.
And go through, if you don't mind, because how big of a deal this is that when you have 4 fingers but without a thumb, and now that there is a thumb, what can they not have done in the past that they can now with that thumb? And I imagine you talk to families about this all the time. With this surgery, we can A, B, C, and D.
Yeah, I mean, you would have to meet and speak with people who are missing their thumb after having it for a long time. And those are people who've lost their thumb owed to cancers or traumas, most often in table saws, or the injury I would see, or even gunshot injuries or firework blast injuries. It's a huge barrier because you don't have something to oppose or pinch, and you lose all your pinch strength. And you lose this digit that can circumduct. And what that means is a thumb can make this huge arc all the way around the hand to touch the small finger. Notice I don't call it a pinky. Hand surgeons don't use the term pinky.
Oh, not the pinky finger.
It's not the pinky finger. It's a small finger.
The small finger, the littlest one on the hand.
That's
okay.
Right. But the thumb is there and can touch every other digit. You know, it's very
that's an
challenging to
excellent point.
take your index and touch your small finger
Right.
versus your thumb and touch your small finger. Feel the power, that pinch power you can get between your small finger and thumb.
And
Now
I'm just
try
thinking
and-
about this muscle. If you have to create this muscle from scratch, because you're right, that is,
So that's another great question. We don't create that muscle. We borrow other tendons in the wrist and the forearm to recreate that muscle.
Oh,
so
talk about that then.
Let's feed
Yeah.
it forward to the person
Okay.
who's waited way too long to fix their carpal tunnel. And that nerve compression at the carpal tunnel has really atrophied the muscles at the thumb, so much so that they'll never recover, but they're really important. And so we actually borrow their palmaris tendon or one of their flexor tendons, or even a tendon from around the back of the hand.
so the palmaris tendon is a palm tendon, basically. Is that what you're saying? Okay.
And we rotate whatever we're going to borrow to insert on that spot on the thumb. So we reroute a tendon and
Okay.
we give it a new task that's more important. And we basically are robbing Peter to pay Paul. But oftentimes, Peter has some other stuff going on, meaning we
Right.
don't rob too much that it's going to negatively affect another thing. So that's why hand surgery is really neat. I mean, you can do a lot of crazy, cool stuff.
And just connecting the tendons, fine, but I'm still thinking brain to tell the hand what to do. And when you're talking about tendons, again, it's these nerves that your brain is saying, okay, now move your thumb.
Yeah.
How does that new connection for the brain talking to the new digits now work?
Yeah. That's a perfect question.
I mean, that's magic to me. That to me almost seems unexplainable.
So that's sort of the magic also of hand therapy. I can't do anything about what I do without some good hand therapists, which I'm fortunate that Children's in El Paso has them, and there's great hand therapists around town in El Paso, which is that you're right. It's a work in progress, meaning recovery from a lot of these surgeries. It's the surgery and then it's sort of a recovery and a relearning. But amazingly, people do real good with this stuff.
And it's the physical therapy.
Oh, yeah.
Okay. And when you say, oh, yeah, so is this, and maybe there's somebody tuning in that might have this or curious, someone who's been through that, physical therapy right after surgery occurs that week, that day, and then how long?
Depends really on the problem I'm working on. And sometimes I have patients meet the therapist before the surgery. They get a good working relationship. That's really, really important, that they know that there's a positive relationship. Even they just know they can get to the office. And then some surgeries I'll do and they'll immediately get therapy that day or the next day. It really just depends on what the operation is. But I say, oh yeah, because it's like make it or break it. Some therapists can make me look like a rock star genius surgeon. And sometimes if a patient does not do their
Right.
therapy, I look terrible and I get an unhappy patient. So picking, choosing wisely, very important. Having a positive relationship with your surgeon and with your therapist and your whole team is sort of critical to having a good outcome.
You know, and that's actually one of my questions prior to coming here. And it depends a lot on how do you as the surgeon, and I know, and I respect that there's an entire team involved here. There are different specialties, there are nurses, but talking to the parents and the family, who handles that? I know you handle some of it because they have to look at you and trust you're the person cutting into my child. How does that process work?
So,
Of talking to the family just to where they start to feel comfortable, because it's a big deal. I mean,
Yeah.
this is something you do all day, every day. This is their child, and they only have, 4 fingers without a thumb. You're going to fix it. How are you going to do that? And talk me into it.
Yeah.
You
So
know?
this is really, really important. Kids who are born with differences, whether it be attached fingers, extra fingers, a missing hand, the parents are immediately mourning the death of their normal baby, right? So when I have new patient consults, and these are often done in my office, rarely in the NICU, because oftentimes I'll tell the NICUs, like, can you please send them into my office? It's just a much better environment. It's quiet,
makes
it's
sense to
calm,
me.
there's no
Right.
beeping things.
You're a real person. You're not a person at the bedside.
And
standing
we're all
there
a
preaching at
person.
the
And
right.
oftentimes I will have a very honest conversation about my role. I build a relationship with those parents. Like I mentioned, I don't operate oftentimes before a year of age, and so I'll see those families time and time again throughout that period to watch how their baby's growing, that they're thriving, that they're doing awesome, that they're learning to use their hand in a different way than others, but they're doing fantastic. And so my relationship's very personal with the parents, and I get to know them very well, and then I get to see them grow and grow and grow. And, you know,
Right.
I've been in El Paso a couple, 2.5 years, and my hope is I'll get to see a lot of these kids when they're 17, 18, 19, and they get to bring home their wives eventually or their husbands. And so it's very personal to me. That said, I am in a team, and this is a team sport. And so when they enter the hospital, they're in a new environment with lots of people, and I'm there with them, and I'm there in pre-op, but I get to ensure them that the teams that we have here are just awesome. I mean, they're kid-focused. We do this every day, but we do not take anything for granted, meaning we may do this every day. It is our job. But we know that this is special, and it's special things that we're doing and taking care of, and we don't ever, you know.
Right. It's not just like, hey, whatever.
Yeah.
Question to you is, I know we've been talking about very young ones, and you were talking about a 1-year-old's hand is huge, and I respect that. Just in your time practicing and doing surgeries, what has been the oldest person that you have operated on? I love case studies. I love just stories that is unique, and maybe this person, you know, we didn't get to him till he's 8 years old for whatever reason, or we didn't get to him till he was 15 years old for whatever reason. What is a case study that sticks out in your head that's unique, a little bit different, that we may not have talked about yet this evening?
Oh, man.
And I'm sure there's so many.
There's a lot. I mean, one of the more striking ones is a young girl I'm taking care of in Juarez as part of the FEMOP group that Children's links up with. It's a girl with a really challenging problem. She had a bad infection in her forearm. It's something that we don't see that often because she lost a huge section of bone.
Oh,
And
my. Okay.
The radius bone is the bone on the thumb side of the forearm.
Right.
So we have 2 forearm bones. The ulna is on the small finger side again.
Okay.
And the radius is on the thumb side. She's missing a big length of radius bone. And so we did that surgery that you now have learned from Dr. Brokoff, which is moving the fibula bone, which can be used to make a mandible, but it also can be used to make a radius. So we've made her a new radius bone, and her forearm was corrected in length. And now we'll have to go back and do some revisions, but I'm just excited because it's going to be a project, but we're going to get her so much better, and it's so exciting.
So out of curiosity, when she lost part of that bone, was it through an accident? Was it through, and again, there's no names or no nothing, there's no identifying this person, but just curious of how did the infection occur?
So those infections occur from breaking the bone, and it's common things that we see in El Paso amongst the pediatric orthopedist surgeons or the pediatric surgeons, which is break the bone, but the bone has a little poke hole through the skin, and the bacteria enter, and so on and so forth. The bone gets an infection, the fracture doesn't heal, and then ends up losing a section of that bone.
My goodness. So you were talking about the work that you do in Juarez, and I'd like for you to expand on that just a little bit, because I'm very familiar with FMOP and all the work that they've done now for decades and decades. How did you get involved with that, and what are some of the issues that you are facing over there? And do they come to Children's to get their surgeries,
That's right.
etc.?
So that operation, for example, was done in Children's, where we moved the leg bone to the arm bone and transplanted it.
Okay.
There is a relationship between FEMOP and Children's, and I am just so lucky that there are kind of giants whose shoulders I could stand on, which is Jack Heidemann and the Heidemann family. And they allowed me the opportunity to work with them, and then with Fabian Calderon, their therapist, who's outstanding. And so I will accompany actually the oral maxillofacial group, who's doing a lot of the cleft and craniofacial surgeries, Dr. Yates and team. And we'll go once a month, and I'll see patients with hand and nerve issues. And we're to the point where we can safely operate at the hospital in FEMOP, meaning
Okay.
provide the same quality of care and feel comfortable and confident in that. It's fantastic. And I know FEMOP is trying to expand, as is Children's. So I think it's kind of a symbiotic relationship between the two and between our sister cities growing and thriving together.
I love hearing that. There's so much going back and forth too. I'm a Rotarian. Why does that matter? Because we've been working on the cleft palate program forever and ever, I feel like. And there's a lot of shared doctors back and forth, and I love that relationship. I also really like, with FMOP, I got to tour their facility, probably 2018 at this point, when they were just rebuilding out some new stuff. And I was fascinated by it all. And I just, again, love the relationship between our doctors and the Juarez doctors, and they're one and the same in so many ways.
Yep.
I want to talk a little bit about, because this still fascinates me. I know that we did a show a while back on brachial plexus, and I'm still fascinated with how you're able to go in. So let's talk about, number one, let's talk about what it is. That might be helpful for those that weren't tuned in on that. But what is brachial plexus, and how does it usually occur?
So brachial plexus, that name comes from kind of a group of nerves that go from the spine into the arm.
Okay.
And those are the nerves responsible for moving the shoulder and the elbow and the wrist and the hand. So if you imagine you injure those nerves, the outcome is kind of a paralyzed arm or partially paralyzed arm. Brachial plexus birth injury is a problem that arises at or around the time of birth to those nerves, resulting in a baby that's not moving the arm or not moving different parts of the arm.
Okay.
In a nutshell.
In a nutshell. So when this happens at birth, what is happening? And I remember you talking about, I'm just visualizing the birth canal and visualizing the placement of the baby, normal placement, head comes out, shoulders come out together, but sometimes shoulders get stuck.
Shoulders stuck, which is called shoulder dystocia. That's the biggest risk factor towards the development of plexus injury. And what I try and tell families and I try and tell OBs is that this, birth is a life-saving maneuver. For a long time, births didn't result in a live baby or live mother. So medicine has come a tremendous way, and there's still issues, and this is one of them, where birth injuries can occur. And it usually occurs from a shoulder that's stuck in the birth canal, or it can come around because baby is very, very large, or other things were done to save baby's life or brain at the time of birth. And I am not an OB, I'm not, these are things that can come up though.
Right. So when you now are called, baby is now born, and mother's okay, thank goodness, but now baby is in a situation where, I keep doing that to the table, where the shoulder's misplaced, you've got nerves, you've got displacements.
Yeah.
Where do you come in? What do you do?
Yeah, we're going to do a hand exam after this.
Okay, yes, we are. Exactly, right here.
Good. So my role is part of this brachial plexus combined specialty clinic, and I helped develop it along with David Jimenez at the Children's Hospital. And we're a monthly clinic. And again, it's a situation where oftentimes I'll run up to the NICU or I'll go to the newborn nursery and just have a kind of cursory look and short talk with mom or dad, but really get them into the clinic, because everything happens there, meaning we have really excellent OTs that are trained and therapists who can look and see exactly what's going on with baby and their arm. Dr. Jimenez and I meet together. We have a time set aside just to do this thing.
Oh, wow. Good. Okay.
And a special clinic for it. And the long story short is the diagnosis is clinical. There's not a big MRI or a big scan that we do to ensure we don't do needles, which is all those things that people are getting with their carpal tunnel syndrome. So I want to ensure you we're not poking babies with needles everywhere.
Oh, dear gosh. Yeah.
So it's a pretty pleasant exam, with the exception for the older kids. We kind of torture them. We stick out candy and toys and bracelets and things and swing it in front of their face. And that's the only way for them to show us what they can and can't do.
Interesting.
And they get really upset if their arm's not working as well as they want it to work. But
how else can you tell? That's such an excellent point.
That's how we do it.
And when you're looking at then surgically fixing, again, you talked about nerve endings, and just when you are fixing a joint, when you're fixing something that is displaced, can there be permanent nerve damage if the trauma was too big? Or is that something that you can always go in and somehow fix the nerves?
So-
Again, Rob
so-
Peter from Paul, what did you say earlier?
That's right. And I
Okay.
do that every day, all day.
Okay,
So
yeah.
we're fortunate that the majority of these recover on their own, meaning 80% of these nerve injuries recover over time without the need for me. So I kind of disappear, and what happens is a lot of therapy and monitoring to make sure they're recovering where we want them to go. The babies or the children that aren't are the ones that we may think about as surgery. And I do a lot of different types of operations, and everyone is kind of custom or bespoke. And we're looking to improve functional things like a baby's shoulder moving forward, or their ability to flex a bicep or hold their wrist straight.
Right.
And so we're targeting our nerve surgeries towards those different functions. And we can sometimes do very, very targeted surgeries, meaning not rob too much of Peter to pay Paul. And sometimes we kind of have to do a lot if what they're given is a paralyzed arm and we don't have a lot to work with. So we may have to do more intense surgeries and reconstruct major nerves.
So one of your videos, and I didn't get to see it for very long, maybe 30, 40 seconds or so, but one of the videos was a bicep that was not working, if
Yep.
I remember that right.
That's right.
And so we're transforming a little bit now from fingers and toes to now muscles and tendons. But still, what was it that you were doing with that? Again, I just saw it for a moment, so if that doesn't count what we're talking about,
No,
I get to just say, go away, Catherine, let's talk about something else.
That's amazing. So what we're talking about is the long-term outcome of a plexus problem could be failure of the bicep. And what that means for a person is, imagine, try on yourself to put your hand to your mouth without using your bicep. Can you do it?
I can take it with my other hand.
Yeah, so you take it with your other hand, right?
Right,
And that's
right.
what a baby with a plexus issue would. But you're even using your bicep there. More
right, that's true.
importantly, the
Yeah.
bicep, what else does it do? It supinates the wrist. That means it rotates the wrist into a position that's palm up.
Right.
So a baby with a plexus problem will be palm down
Always palm down.
with an extended elbow.
Okay.
And we call that a waiter's tip position because they're waiting for their tip behind their back, like a waiter.
Right.
So in that young baby, their outcome was that they were not recovering their bicep on their own.
Interesting.
And it's really important to get a bicep because it rotates the hand.
Right.
And it can bring the hand to the mouth. So it changes someone from whose arm could not help them brush their teeth or comb their hair or even wash their hair into someone that can. So it's critically important to get that nerve working again. And so I did a operation that borrowed from their wrist flexors, meaning the nerves that help the muscles flex the wrist forward. Because you have two wrist flexors and you have multiple nerves going into those wrist flexors, you can borrow one without borrowing too much.
Right.
And so I borrow one of those, which is running right alongside the bicep nerve.
Okay.
And I reroute it into the bicep nerve. So it's literally like unplugging a cord and plugging it into a new socket. And it's not...
And you're not really taking anything away from functionality.
Exactly.
Okay.
So that's what it all comes down to. That's my life every day in a nutshell right there.
You said something at the beginning of the show when you said you were able to split an artery and split a nerve. And I didn't want to stop you from talking because I tend to do that. I hear something I don't understand and I stop you because I think we're going to get way too far into this and I want to understand. But when you said split an artery and in essence make that into two, am I understanding that correctly? And if so, how do you do that? Are you because you're lessening the size, obviously. So is that artery just a lot thinner now? And maybe I misunderstood you.
I think we were talking about the separation of fingers,
I think
where
we
there's
were.
an artery splitting into the two fingers, and I'm preserving those two.
Okay.
But you can, for example, and we do this with those transplant operations, is bring an artery from somewhere else and connect it to the side of another. It's called
Maybe
an
that's what I was thinking about.
end
Okay.
to side connection. If you pictured it, it's almost like a tube running straight.
Right.
And then a T point, meaning it's a T point off that tube
Got
to
it.
reconnect it to its side and get blood flowing in several directions.
Geez. Okay. And same thing with the nerve.
Same thing with
Same
the
thing
nerve.
with the nerve.
So those transfers are literally splitting the nerve, and then I will sew it either into the end of a nerve that I cut that's not working,
Right.
or into the side of a nerve that's partially working, but it needs a little more oomph or gasoline to it.
Got it. And you said earlier too, all surgeries are cutting and sewing.
Cutting and
At the end
sewing.
of the day.
That's it.
Yeah. I was joking about MASH for those of us that are old, and Hot Pants Houlihan was trying to describe to someone who had to do a surgery that wasn't a surgeon that you just cut this and you sew that.
That's
Go get
right.
My sewing kit. So when you said that really kind of made me giggle a little bit. I do want to let the audience know that we had a couple of doctors that were scheduled to be here this evening, but again, this is a pediatric surgeon show, and sometimes things happen, and we have two doctors actually in surgery right now. And so I wanted to give a shout out to Dr. William Spurbeck, who is the chief of pediatric surgery at the El Paso Children's Hospital, and he is in surgery as we speak. And then we also had Dr. Jonathan Chow, who is the pediatric ENT at El Paso Children's. They were both going to be here, and Dr. Chow is helping Dr. Spurbeck with the surgery. So on that note, guess what you get now, Dr. Diamond? Dr. Diamond, I know we said at the beginning of the program.
Probably a call into the OR.
You're going to get a call to the OR, and or you get to answer some ear, nose, and throat stuff that we completely know is not your specialty.
Perfect.
Right, I know it. And so in this program too, there is always a disclaimer saying, whatever you said, you can't be sued for because this is the opinion of what's happening here. So I say that just so the doctors are like,
All right.
it's not my specialty, but this is what I think it is. Some of the most common pediatric surgeries, aside from what you do, I know we're talking about microsurgery, we're talking about
Sure.
hands, but common pediatric surgeries that your team deals with. If Dr. Spurbeck were whispering in your ear right now,
Yeah.
what would he be saying for you to say?
Yeah. So, I mean, as far as the ear, nose, throat work, I would say tonsils and adenoids, we call them TNA. I would say ear tubes, very common to decompress chronic ear infections, although I don't even know.
Right.
Again,
My brother had those, I remember. So he is now, my goodness, he's now 50.
exactly.
And when we first came to America, I remember that being one of the first surgeries I ever heard of.
Exactly.
And he had tubes put in his ear. And we're like, how do you put tubes in the ear?
As far as general surgery, meaning general pediatric surgery that Dr. Spurbeck would perform, things like hernia, so inguinal hernia or umbilical
Hernias are
hernia.
Super common. If
Very
you want-
common.
Yeah, if you can kind of talk a little bit about that. I know it's not your specialty. I get it. I do respect it. But describe what a pediatric hernia is. So an umbilical hernia, just describe what it is. And even just physiologically, not how we would do the surgery, but what the surgeon is trying to do to remedy that.
Sure. So again, preface it with I am a plastic surgeon.
Understood.
I did train in general surgery. I am board certified in general surgery. So I did some, but I'm glad that there's a disclaimer at the beginning of the show.
Yes.
I'll explain my limits, but a hernia in general is an opening in any place, but let's say abdominal hernia is an opening in the abdominal wall. You can think of it kind of like a sleeping bag. And if there's a hole in your sleeping bag, something can punch through, like a hand or a fist.
Right.
And in the case of a hernia in the belly, like the belly button, that hole never quite closed, and little chunks of fat from inside the belly or even intestine can escape out. That's not common. Oftentimes, umbilical hernias actually resolve on their own, meaning they go on to self sort of heal.
My son had one, and yes, it healed on its own. Thank
That's
goodness.
right.
But yes.
And they occur in different areas, meaning belly button is umbilical hernia, inguinal, which is groin, which my wife had as a very young baby and had fixed. And I know that I wish Dr. Spurbeck was here because he would explain that for all the older people in the audience who have incisions on their belly because they had surgeries when they were young babies for these types of problems like hernia or pyloric stenosis, very common things. Sure.
Right.
Now, Dr. Spurbeck and others are able to do a teeny tiny micro incisions. And again, we talk about cutting, sewing, tubes, etc. But on the flip side is instrumentation. And to do microsurgery, we need amazing microscopic instruments. And to do general surgery, they need to do it with amazing optics, meaning little tiny video cameras, which have great visualization of all these little structures, and little instruments so that they took things that were big incisions on bellies and made them tiny micro incisions, hiding them in belly buttons.
So we were talking about pyloric stenosis. So we were talking about how to fix it, but what is that? And I remember my brother's now 58, has that nice big scar on his belly because he got it when he was, a couple of months old, if that. What is blocking? What's in the way? What's happening there? Just digest. And how do you know as a new mom or a dad? Those are the big questions.
Perfect. So let's go to how you know first.
Okay. Done.
And we'll start from there.
Okay.
So how you know your child may have a pyloric stenosis is their projectile vomiting. And I'm not talking about spitting up milk or you're patting baby, a little milk spit up. I'm talking about across the room, hitting your face, hitting the wall, projectile vomiting. That is very, very, very important. Not green.
Not green.
Not green.
Okay, that in and of itself asks questions. Why? What's the green portion of it?
Perfect. So in pediatric surgery, there's green vomiting and not green vomiting. And that triages a huge difference in the problem.
Okay.
And the reason being is that the pylorus separates the stomach and the duodenum, which is the first portion of the small intestine. Your gallbladder enters into the duodenum. So imagine if you were throwing up and had a normal pylorus, the throw up can be green because the stuff in your small intestine gets into your stomach, up your esophagus, out your mouth. If you have a pylorus that's blocked, that has a muscle that's just spazzing out and super overgrown, blocking the stomach from the small intestine, you're just throwing up the contents of your stomach. So that's why it's non-bilious, which means not
There's no
green.
processing happening yet.
And it's just the stuff in the stomach and it's going right to the other wall in the other room type of vomiting.
Oh God. Okay. But that makes sense. When you describe it that way, that makes perfect sense. We were talking about umbilical hernias. We talked about that. Abscesses. I know this is gross, but abscesses in general, as a surgeon, but it happens with kids all the time.
Happens in hands and fingers all the time.
Okay, describe a little bit of that. Infections at the end of the day, right?
Infections are common.
Yeah.
And infections in skin and soft tissues are common, meaning in feet where kids step on glass or splinters and get infected, in hands where splinters go into hands, get infected, or thorns, etc. And down near someone's bottom, and the kids that are a little older and have a little bit of hair in their gluteal cleft, often a very common source of infection.
You know what? We never talk about that because it's gross. And we're here to talk about gross stuff because that's what we do on medical shows. So again, as a parent, and let's talk about ages too. So as a parent, how do you know this is going on if the child doesn't know what's going on? Obviously, it creates some kind of pain. There's some kind of an abscess. There's some kind of et cetera, et cetera. What is the parent looking for?
So
how would they know, for example?
I mean, mostly an honest conversation, because again, these kids are of speaking age, usually in their teens, et cetera.
Okay.
And they may have drainage on their underwear. They may feel like they get wetness on the underwear or foul smell on the underwear. That's not, when they're
And
defecating.
I'm thinking a teenager, is he going to go tell mom or dad?
Probs not.
Yeah.
So
that's one of the reasons I'm, how does one know?
I think just
But-
having an honest conversation.
Yeah.
Yeah.
So asking the kids every now and again, what's going on in your life?
Yep.
We have a whopping 2 minutes. Is there anything we haven't talked about yet that you want to throw out there really quick before we wrap
Man,
up?
that was a huge array. I'm just so bummed I didn't have my buddies here to talk with.
I know. Well, we'll do this again. This would be a lot of fun because there's so many things that we can talk about. With pediatric surgeries, you have a very specialized discipline.
It's true.
And it's fascinating to me. And I can't wait to go back and watch this and check out some of the things that our rock star Diego, so we have Diego Munoz here. Muniz. Jeez Louise, can you tell it's been a long hour? But Diego's the one that intercepts all of these things and finds videos. And then we also have Daniel with us. And who's doing audio in the back?
Mike.
Hi, Mike. Thanks for doing Mike. Mike, appreciate it. And who else?
Victor.
And Victor. Mike and Victor, too. So these are the rock stars at Star City Studio where we're able to do the El Paso position over the last several months, and it's really been fun to do that. So again, I want to thank El Paso Children's Hospital. They underwrote the program this evening, and it's been really a lot of fun for me to learn more and more. And I'll tell you what, this fibia and other bones that we're using to fix things is absolutely amazing. If you only caught part of this program and want to watch it again, you can do that at several different places. You can do that at pbselpaso.org. Just look for the whatever show it is that you want to see. If you want to go to the El Paso County Medical Society, that's EPCMS, just think of the acronym, that's a .com. And you can also go to youtube.com and look up the El Paso Physician. And the nice thing about all three of these places is that you can go back and find different programs that you might be interested in. I'm Catherine Berg. I appreciate you joining us, and thank you very much, Dr. Diamond, for being here. And we'll bring your buddies along next time.
Awesome, Catherine. Thank you.
You're very welcome. This has been the El Paso Physician. Goodbye.